Okay, we are live on YouTube.
Oh, good.
Right. I'll just reshare the link with everybody.
Oh, it's a new link.
So it says it's the same. Just a second.
Let me see. Let me see. I can see.
Yeah, it is a new link. So the YouTube has canned the previous link. So just a second. Let me see
So
if
the
I can.
previous link won't work. Let me see. Yeah.
Let me just try to switch it to the previous link.
No, the previous link is not working.
So should I send you the current link?
Oh my God. Okay, there's no other way. I'll redistribute it.
Just a second. Let me try to do this again.
Like we are live on YouTube. Maybe it's working.
Let me just try to switch it to the
Just log into your in the YouTube. Just log into your page. That RC Medicure page. In that page, you're live.
No, the previous link is not working.
Okay. So should I send you the current link?
Oh my God. Okay, there's no other way. I'll it's live.
Just a second. Okay. Try to do this again.
Like we are live on YouTube. Maybe it's working.
Let me just try to switch it to the
Just log in.
Sir, it's still showing me waiting.
No, it's not working.
Yeah, it's still showing waiting. I think.
No. You have to go into your YouTube page. Go into your YouTube page.
Yeah, so that's what. It's a new link.
Yeah. So go into your YouTube page. Click on the first video. It's live.
Right. So it's a new link. I'll just resend that.
Okay, send the new link there. Let's
Yeah.
watch.
I think.
No. You have to. Into your in the YouTube, just log into your page. That RC Medicure page. In that page, you're live.
Okay. So should I send you the current link?
Oh my God. Okay, there's no other way. It's live.
Just a second. Okay. Try to do this.
Like we are live on YouTube. Maybe it's working.
Let me just try to switch it to the
Just log in.
Sir, it's still showing me waiting.
No, it's not working.
Yeah, it's still showing waiting. I think.
No. You have to go into your YouTube page. Go into your YouTube page.
Yeah, so that's what. It's a new link.
Yeah. So go into your YouTube page. Click on the first video. It's
Okay, Meg, I think we'll distribute the news link. I think
Yes, we've already started. We've already started with that.
Oh, you start the program. We'll share the new link and people see can see the recorded version.
Okay. Okay, sure.
You can start. I'll share the link. Yeah.
So we'll just wait for a couple of minutes.
Okay, Meg, I think we'll distribute the news link.
Yeah, so we already started.
We've already started with that. Oh, you start the program. Start the program. We'll share the new link.
Okay. Right. So good evening, everyone. Welcome to Together with AMR, AMR being antimicrobial resistance. I'm Rotary Meg Nagvekar, the president of the Rotary Club of Medicrew. The Rotary Club of Medicrew is a pan-India non-profit organization of medical students. Currently, we have about more than 3,000 members all over India, striving to achieve success with our motto of Dare It, Dream It, and Drive It. We believe in leading through adversity, through healthcare, to the stars. So today we have with us Dr. Anup Warrior, Dr. Nitin Bansal, and Dr. Yamuna Devi, who are the speakers for today's program. Along with them, the student panelists, that is myself, Dr. Meg Nagwekar, a third-year MBBS student at KJ Somaiya Medical College, Dr. Diksha Sen, a BDS intern at AB Shetty Memorial, AD Shetty Dental Science Institute in Mangalore, and Dr. Adnan Acharwala, who's a professional development director at the Rotary Club of Medical, and also a second-year MBBS student at the Cooper Medical College. So I think we'll also have a short introduction about the AMR Trust, in collaboration with which this seminar is happening. So over to you, Dr. Anup.
Thank you, Meg. So I'll take a minute to introduce the trust to our people. So AMR Declaration Trust is a public charitable trust. This was founded on the principles of Chennai Declaration. Chennai Declaration was one of the earliest initiative to begin a multi-stakeholder collaboration for handling or addressing this complex AMR issue way back in 2012, and then published its recommendation in 2014. So the AMR Trust is built upon these principles, and we comprise of not just physicians and microbiologists, but we have all the stakeholders, scientists, technology experts, NGOs, policymakers, pharmaceutical industry, etc., in this endeavor to bring together all the required people to address this complex problem. And our objective remains to promote and support the collaborative efforts to address this problem of AMR in a very constructive fashion, and we focus on innovation and education to reach this goal. So this program today is also a part of this initiative, a part of this objective, that we take up this education to our medical trainees also, and we are very hopeful that this will go a long way. Thank you. Thank you, ma'am.
Thank you so much, Dr. Anup. So I'd like to introduce our first speaker, Dr. V.R. Yamuna Devi. She's a consultant infection control at the CSSD and OT coordinator at Apollo Hospital, Chennai. She'll be talking about what is antimicrobial resistance. And over to you, Dr. Yamuna.
Thank you, Meg. I'll be sharing my slides. So a short and crisp presentation on why are we talking about antimicrobial resistance. As said by Dr. Joshua Lederberg, the future of humanity and microbes will likely evolve as episodes of our wits versus their genes. So whichever wins will take over the world. So what is antimicrobial resistance? Antimicrobial resistance is resistance of a particular microorganism to an antimicrobial drug that was originally working well against that particular organism for the treatment of infection. And these resistant organisms are able to withstand the attack by the antimicrobial drugs, so that the standard of care or treatment for the patient becomes more difficult and ineffective, and thereby the infection persists, and also there are issues related or to spreading of these infections. So this is an example to say what is a natural selection of resistant bacteria. On the left side, you see a population of many susceptible bacteria. There may be few resistant bacteria which can be related to inherited resistance among them. But when you give an antibiotic challenge to this population of susceptible bacteria, it leads to killing of all the susceptible bacteria and growth of more of resistant population, and thereby it selects out the mutants or selects out the resistant bacteria. How does the antibiotic resistance move directly from germ to germ? So the resistance is usually of two types, either an inherent resistance, which the bacteria has on its own in order to protect itself from the surrounding environment. It can be related to a reduction in the influx pathways, and few other commonest cause of resistance which they acquire is the acquired meaning of resistance, which is the commonest reason for the hospital-acquired infections or the cross-transmission of infections which is happening in the community. So how do they acquire? The common reason are the mobile genetic elements. It can be a plasmid, a transposon, or a phage related. If it's a phage related transmission of this mobile genetic elements, it is called as transduction. And the second one is because of conjugation, when there is a close contact between the bacteria, or it can also be a transformation when the resistant mobile genetic element is picked up by another bacteria when it is nearby to a dead or dying organism. So this is how the selection of resistant bacteria which we saw, when this selection of resistant bacteria happens at the site of infection, it leads to a treatment failure. Again, this natural selection of bacteria, when it happens in the normal flora, it leads to a colonization, and thereby colonization, the transmission of this particular resistant bug or the resistant bacteria in the community. So that is how the resistant selection of bacteria plays a major role at the site of infection or when it is in the normal gut flora. Usually how the bacteria or the fungi fight back against antibiotic. That is, what are the different mechanisms of antimicrobial resistance? Either they restrict the access or entry of the particular antibiotics into their cell wall. It can be because of the increase or reduction in the porin channels or a mutation at the level of porin channels. The second most common is the germs change or destroy the antibiotic with certain enzymatic production, which is very commonly the beta-lactamase enzyme secretion. It can also be because of they try to get rid of bacteria by more or hyper functioning of the efflux pumps so that it doesn't allow the antibiotics, even if it enters, it just pushes out of the bacterial cell. Or they can be alteration of the target cell, thereby the antibiotics are not able to bind to the site of action. So these are some of the ways by which the microorganisms will fight against the antibiotics. So the two major drives of antimicrobial resistance is one, unnecessary antibiotic pressure, thereby leading to genetic selection, that is genetic mutation or the selection of resistant mutants. And then the second drive is the risk of cross transmission. So you select something, you create something, and you spread it out something across the community. So whatever happens at one side becomes a catastrophic event in the community on the whole. Not only antibiotics are used for human use, but they are also used in livestock. For example, it's used for the treatment of disease, also as a prophylaxis for prevention of disease among these livestock, and also as a growth promoter, increased feed to gain efficiency. This is very much wondering to see that the antibiotics which are consumed by human is only 30%, whereas the consumption by the livestock is around 70%. Not only in livestock, but also in aquacultures, these antibiotics doses are so higher, proportionately higher even as compared to livestock. And 70 to 80% of these unmetabolized antibiotics or antimicrobials are left out in the water so that it is there in the community or it is there in the water system, which comes back to the human food chain. Some important facts that according to FDA report in 2011, 93% of these medically important antibiotics were administered either via feed or water in agriculture in the US. And 75 to 90% of these antibiotics are just excreted unmetabolized from the animals and enter into the sewage system and water resource. And these water resources are the animal manures are used for the cultivation of crops. Thereby, it leads to even the crop related resistance, and thereby it enters again into our food chain. According to this particular document, out of 41 antibiotics which are prescribed for the human use, 31 are the major medically important antibiotics which are deemed or medically important used for human use, but 41 among this are used among the livestock, or it's also used as the antibiotic use in the aquaculture. So the important antibiotics which is reserved for human use are used in multiple places, not only in human, but all these places. So how does this antibiotic resistance spreads? It begins with two different aspects. One, antibiotic exposure of human or antibiotic exposure of crop or the livestock. Thereby, from their food chain, it enters into the crop by utilization of the manure or by the sewage water getting contaminated. The same water is used for the crop growth. It comes into the human food chain. They get colonized, and someone who pops one antibiotic get colonized with resistance, passes on the resistance but either to the contaminated water or a poor sanitation system. The same person, when he reaches the hospital, it can be a cross transmission from that person to the another person, and thereby the third person who walks into the community would have acquired this antimicrobial resistance. So that's a worry. What we used to see in lab as drug susceptible bacteria, now it has become a multi-resistant bacteria. So what are the clinical and economic impact? The clinical impact, what we have is major life-threatening infections. We are devoid of existing antibiotics. There are many cancer patients who require these high-end antibiotics or important antibiotics in order to avoid and fight infection. The third aspect is we have moved more into technology-wise where we have started doing more of organ transplant, more complex procedures like robotic procedures. If those patients end up in infection, then all the more it would have a very bad clinical impact. So this is a small study which differentiates between the resistant bug and a susceptible bug, which says that the median time for resolution of symptom-resistant bug and symptom resolution rehabilitation in OPD is more for a resistant bug, and the significant presence of bacteriuria or bacteremia in a resistant bug is more. That means there would be a repeated visit of such patients back to the hospital, and clearance of this bacteria from their system would also take a longer time. When we look into the economic impact, there will be more than $100 trillion loss by year 2050. So we are already fighting a losing battle because of the emergence of resistance and also because of the existence of resistance. How many ever new antibiotics comes into place, the resistance follows it like a shadow. So this is the overall global burden of bacterial antimicrobial resistance published by WHO in 2019, which says that the carbapenem-resistant Klebsiella pneumoniae all across our country is somewhere between 50 to 60%, which is very common in few African countries. Whereas in European countries, the rate of infection related to carbapenem-resistant Klebsiella is somewhere between 5 to 10%. So this is the overall susceptible trend of Klebsiella pneumoniae, where we see the important carbapenem drug sensitivity pattern has dropped down to 40 to 50%. Very good even for the carbapenem-resistant Acinetobacter, where the whole of Russia, the part of South America, the whole of India is actually shows a resistant trend of somewhere more than 80% carbapenem resistant related to Acinetobacter. And when we choose Acinetobacter, as we can see, most of the first and second line drugs are completely resistant, and the susceptibility is hardly between 10 to 20%. So we are left out only with the high-end antibiotic like colistin or polymyxin B. This is a very good data compiled and given by ICMR, where the antimicrobial resistance surveillance network has been functioning since 2013, where the regional centers keep uploading all the antimicrobial resistance pattern which is generated in the setup, so that we have a compiled antimicrobial resistance data as of now till 2021. The report till 2021 has seen 95,000 isolates, which says that the commonest bug which is seen in the intensive care unit is Acinetobacter. As we have already seen the susceptibility pattern, carbapenem resistant is 80%. So if it is ICU-related Acinetobacter, the treatment of choice is again polymyxins. The commonest bug in ward or in OPD is E. coli, followed by Klebsiella, where their sensitivity pattern or susceptibility to carbapenem is only 60%. Some highlights of this AMR data about gram-negative. The imipenem susceptibility of E. coli has dropped from 86% to 64% in a period of 5 years. Even the cephalosporin sulbactam sensitivity has dropped down from 65 to 43%, and resistance to carbapenem and Acinetobacter has increased to 87.5%. Whereas the susceptibility pattern of Salmonella typhi has been predominantly good for the first line of antibiotic like ampicillin, cephalosporins, azithromycin. So these are the determined group of bugs or resistant pathogens commonly found in the Indian hospitals, on which the focus is maintained, which is divided into group 1, which carries a high priority, for which we require an aggressive action, which is very different as compared to other Western world. The reason why, because our commonest problem in today's hospital scenario or in Indian scenario are the carbapenem resistant gram-negative bacteria, particularly Enterobacteriaceae, carbapenem-resistant Acinetobacter, and drug-resistant Salmonella typhi. Among group 2 only, we have considered ESBL, Pseudomonas aeruginosa, and VRE, and group 3 comes the Staph aureus or the MRSA. So that's a major difference between the Indian scenario and other countries. So the aggressive action should be more focused towards the carbapenem-resistant Enterobacteriaceae and the carbapenem-resistant Acinetobacter. So what do we mean by multi-drug resistant organism? If it is not susceptible to one or more agents in 3 or more below given antimicrobial classes, can be related to aminoglycosides, third or fourth generation cephalosporin, fluoroquinolone, beta-lactam and beta-lactamase inhibitor, carbapenems. So this is the trend of MDRs in E. coli, which is 43%, in Klebsiella it is 63%, and in Acinetobacter it is 87%, and Pseudomonas it's 36%. If it's XDR or extensively drug-resistant gram-negative pathogen, that means it is not susceptible to one or more agents from 5 antimicrobial agents, and this is the trend. For E. coli, it's 6.67%. Klebsiella, it is around 12%. In Acinetobacter, 55%. And for Pseudomonas aeruginosa, it is around 6%. When we look into the gram-positive bacteria, the Staph aureus susceptibility to erythromycin, clinda, and ciprofloxacin cotri is very good for methicillin-sensitive Staph aureus as compared to MRSA. But we are seeing an increasing rate of MRSA pattern from 28%. Now it's currently going towards and above 42%. Whereas the other MRSA related antibiotics like vancomycin or daptomycin, it show a very good and excellent susceptibility pattern. When we look into the second commonest gram-negative positive bacteria, the Enterococci, Enterococcus faecium has become more resistant to the vancomycin as compared to Enterococcus faecalis, but the overall vancomycin resistant rate is around 14.9%. Even when we look into the fungal pathogens, there has been increased rate of Candida auris reporting recently, and after COVID, the reporting of Candida auris has been tremendously increased. And the most important factor of Candida auris that it is one of the multi-drug resistant antifungal drugs are commonly seen in Candida auris. And 90% fluconazole susceptibility in Tropicalis albicans and utilis is seen, but the fluconazole susceptibility has definitely come down for Candida auris and Krusei. So the only and commonest solution to this approach towards this antimicrobial resistance is that we need to preserve the existing antibiotics for the future generation. And it is possible only by having an appropriate antimicrobial stewardship at all levels, not only at the human population level, but also at the agricultural level, at the livestock, at the aquaculture level, and to maximize the infection control practices, not only at the level of hospital, but community-wide. And the last is to limit the spread of these resistance. So I would say that is the major and important conclusion in order to prevent the spreading antimicrobial resistance. Thank you.
Right. I think that was beautifully covered by Dr. Yamuna. So we'll be opening the forum for about 5 minutes on the YouTube chat box for any questions directed for Dr. Yamuna regarding her PPT. So if you have any questions, please put it on the YouTube chat box and Dr. Yamuna will address the same. Right, Dr. Yamuna, so we have a question from Sanvedana K. can we bring that treatment again? We know the major problem is mutation in bacteriophages, but may be good treatment to for entamoeba H and E. coli.
Yeah, the phage-related treatment or the prevention of resistance is under trial. It has not come out as a complete method to prevent antimicrobial resistance or as a treating modality, but it's all under in vitro studies. As of now, it's not available in vivo in order to prevent this antimicrobial resistance, but definitely it looks like that's the way forward. And even bacteriophages are used as a part of one of the disinfectants in order to kill these antimicrobial agents, the antimicrobial resistant bacteria which is present on the environment. So these are all the innovative studies which is happening. Yes, if it comes into practice, then that would be a really a new future or a new trend for prevention of antimicrobial resistance.
Okay, I think there are no more questions as of now. So we'll begin with Dr. Nitin Bansal. Dr. Nitin, would you like to present your PPT?
Yeah, I'll start sharing my screen.
Yes, sir. So introduce Dr. Nitin Bansal. Dr. Nitin Bansal from the AMR Declaration Trust is an infectious disease physician at the Rajiv Gandhi Cancer Institute at New Delhi. He's also a consultant to ICMR for the antimicrobial stewardship program under Dr. Kamini Walia. And he'll be addressing the topic of how do we tackle the antimicrobial resistance. Over to you, Dr. Nitin.
Thank you, Meg. Are my slides visible?
Yes, sir. We can begin.
So I've been asked to speak on the topic, how do we tackle AMR? I think they are not moving yet.
So I think you can present the slides. Yeah, perfect.
I don't have any. So I saw this movie called Avatar in 2009 when I was a final year MBBS student, and I was perplexed by the beautification of the director's vision, in which he showed this movie, and I was not able to comprehend some part of the movie also, because I was not aware what he was trying to say. Now, after doing all these complicated studies, doing MBBS, MD, and then fellowship in infectious diseases, and some experience, and now I can relate that actually Avatar had direct correlation with how do we tackle AMR. And as I move into my slides, you will understand, you will get my point. And I also read this novel recently, I think not recently, a couple of years back, The Turning Point by a theoretical physicist, who actually made a strong point saying that when we started with our scientific revolution or industrial revolution in 1600 or 1700 AD, we actually used the Newtonian physics, and to an extent later on Einsteinian physics. Because of which we are currently living at this age where we can communicate with other persons from different parts of the world. The main aspect of these kinds of like Newtonian physics is that it breaks the concepts into various small forms, and we try to solve these small problems and then try to connect them with each other. But what this author wanted to say is that of the last 50 years or so, we have not made any great scientific breakthrough, which we used to make quite frequently in the earlier 19th century and the 17th century. So the major issue is that we are not looking into the problems, the current scientific problems, at a holistic approach. So I think it's time. The time has come up for the Newtonian and the Einsteinian physics, and we need to move on. And now of late, we are talking about something called as quantum entanglement, which basically speaks that something which happens to a particle at one end of the world can affect the spin of the other particle, which can be there anywhere, as separated as by many billion light years also. So something which is happening at one part of the world or one part of the universe is going to affect something which is there at other end of the universe. So something which is affecting my foot can affect my head also, and something which is affecting my bacteria in the gut can affect my bacteria in the lungs as well. So we need to be aware that whatever we do with the body, everything has its own repercussions, and subsequently everything changes. This is also in line with the WHO's One Health approach, where it is no longer believed that if you want to live a healthy life, you just concentrate on human health only. We need to concentrate on other things which are living with us, like environmental health and the animal health as well. So this is something which has come up of late, where we are talking about a one health approach, where we take all the things which all the living things, all the non-living things in the universe, in the world together, and then we try to live a healthy life. This is how we are supposed to solve problems in the future. And AMR is directly and indirectly related to the this approach. Unless and until we have a holistic approach, we are not going to solve the AMR problem. We cannot have a fragmented approach of solving AMR. So AMR cannot be tackled by just blaming doctors or blaming the chemist shops that they are giving unnecessary antibiotics. Yes, that is one of the major issues, and that should be addressed. I am not denying that, but we need to address AMR as a holistic problem. And for that, as Dr. Yamuna told, that antibiotics are not only used in humans, antibiotics are also used for animal health, plant health, and also for environmental preservation. So unless and until we tackle the problem as a whole, we are not going to have any fruitful insights into the AMR problem. So I'm a clinician, so I can only discuss about AMR as from a clinician's perspective in greater detail. Although I will touch about how should we tackle AMR from a policy maker's point of view, from administrator's point of view, and from a public health point of view in a brief in the subsequent slides. Now, from a clinician's perspective, tackling AMR involves antimicrobial stewardship, which basically means an activity which includes appropriate selection of the correct antibiotic with correct dose, route, and duration for which the antibiotic has to be given. Mind you, AMSP does not mean making someone feel guilty about writing an antibiotic. It is just that we have to help that person choose the correct antibiotic for the correct duration of time. This is what practical definition of AMSP means: right drug, right time, right dose, and right duration. And it has been shown in multiple studies that AMSP leads to optimal patient safety, decreases cost, and reduces resistance. And I'll not speak too much about AMSP because, again, it's a separate topic altogether, and there's no point discussing about something which will take a lot of time. So I will briefly discuss what it takes to write an antibiotic when you go to a doctor, or when I write an antibiotic for my patient. The step one is making a diagnosis. Am I dealing with an infection? What sort of a patient is this? Is it a non-infectious problem which is causing which is basically mimicking an infection? Step two becomes how important the antibiotic is right now. Should I straight away write antibiotics, or should I call the patient back after the test? That depends on the clinical condition of the patient. And third is, what antibiotic should I give? That depends on the syndromic diagnosis which I have made and the local resistance pattern of the guidelines which are in place for that place. So I'll just briefly give you two examples. One of the examples is a 25-year-old male nurse who has come with fever, cough, cold for last 2 days. On examination, he is having pharyngeal congestion, and the rest of the exam is normal. What antibiotic should I give? Should I give azithromycin or should I give amoxicillin? Case 2 is a 25-year-old female nurse who has come with fever and headache for last 3 days. On exam, she is drowsy with tachycardia, normal BP, and neck rigidity. Again, the question is, which antibiotic will I give in this patient? Case 1, my diagnosis is clear. It's a viral pharyngitis, and I don't need to give any antibiotics. I'll just give paracetamol and antihistaminics and antitussive for a symptomatic relief. Whereas case 2, my diagnosis is a meningitis diagnosis, and I will not wait for any test to come. I will investigate her, but I will simultaneously start off antibiotics as per the protocol, which is ceftriaxone and vancomycin. So these two cases are quite clear and quite simple. I mean, from giving antibiotic or not giving an antibiotic point of view. But we don't live in a perfect world, so all the cases are not that clear, and antibiotics are needed. Investigations are needed, and as usual, investigations take their own time to come back. So antibiotics needs to be started. So there is a concept called antibiotic timeout, where we actually look into our prescriptions of antibiotics after 48 to 70 hours, 72 hours, reassess our patients, and whether the antibiotics are needed or not, we take a call on that. From administrative perspective, we have moved along. We are not dealing with we don't like to deal with administrators like this who actually try to boss us. We actually want to deal with administrators like Lisa Cuddy in House MD, which sees cooperative, she takes everyone along and moves along with everyone. Not only just, there's no policing around that is happening with an administration. So that's what we do. We don't want. We want good administrators who actually take people along with them rather than just bossing around. So administrators are again hospital administrators and policy makers. Administrators are very important as far as AMSP is considered because They actually form the major component of the core elements of the AMSP as per the CDC, and we require strong commitment from the hospital leadership for AMSP program to be conducted in any hospital. What administrators do well is that they understand numbers very well. So if you give the numbers to the administrators, they will act upon it. And there are good number of studies, and it has been like proven in the medical literature that AMSP actually helps. This is one of those studies in which after AMSP intervention, the consumption of the drug and the incidence of the multi-drug bacteria and the blood cultures have come down after the AMSP intervention. Again, a more famous study from Spain, a multi-center study, which has clearly shown that after the introduction of AMSP, which is shown in the red line, the incidence of the MRSA, so-called superbugs, Klebsiella pneumoniae, Pseudomonas aeruginosa, and Acinetobacter baumannii has come down after the AMSP interventions were started in 2013, sorry. And also you can see accordingly the antibiotic consumption also came down. From policymakers' perspective, again, this is something which is a little tricky. To make the bureaucrats, high-level politicians understand AMR has been the problem, has been the major roadblock, at least from Indian perspective point of view. So, but when you look into the Western world, this is from 2015, where Obama released a national action plan to combat antibiotic-resistant bacteria, and actually this is in great detail given on the website. But as you can see from the major goals which they wanted to achieve in 2020, the approach was a holistic approach. Not only they wanted to establish AMSP program in all the acute care hospitals and all the healthcare settings. They wanted to reduce antibiotic usage. They wanted to target the superbugs, but they also wanted to eliminate the use of medically important antibiotics for growth promotion in food producing animals. This is so we need to take a holistic approach to tackle AMR, again shown by this by the Western world. In our situation in India, things are not that similar. Most of us, I had very little idea about AMR and AMSP and IPC when I was doing my MBBS and MD, and I do understand that most of the listeners to this webinar may not have an idea. Now NMC has come with a regulation that all the undergraduate students should receive should receive training on AMR and AMSP related issues. Now recently, few days back, we had another regulation in which the health minister of Kerala has banned antibiotics without prescription. That means over-the-counter antibiotics cannot be given in Kerala. So these are some of the welcome steps which has been taken by our bureaucrats. But again, we need a holistic approach. Fragmented approach of doing single thing will not work as a whole. From public's perspective, tackling AMR from public's perspective, this is something which is very open, which is has a lot of potential and very poorly understood also. So I came across this paper which has actually surveyed what is the public's opinion about AMR and various aspects of AMR, and this included Indian laymen also. As you will see from this paper, it goes in great detail and they were asked various simple questions also. And as you can see from the slides, most of the people actually did not have an idea. More than 50% of the people actually did not have an idea what is AMR, what antibiotic should they, what actually is an antibiotic, when the antibiotic should not be given, when should it be given, when should they complete their course, etc. These are the basics of health which we should be understanding, but we didn't have understanding. We didn't have an understanding. And also there was a stark difference between what was happening in a high income country and a lower middle income country like India. The knowledge was even poorer in lower middle income countries. So we need to make people aware that they have to take matters in our own hands, like we have done for other problems like diabetes, for example. Now today I got a call from one of my one of my previous teachers who used to teach me in school with a snapshot of his blood glucose showing that it is 285. So he was so aware that he bought a blood glucometer, got a prick on his own, got the level and called the doctor saying that he's having a high blood glucose level. But somehow from infection point of view, we are not aware. We have to become more and more antibiotic aware. And at least this is what I think, that as a patient, then we should be asking our doctors or chemists, even if we are taking over-the-counter medications, which infection do I have? Do I actually need an antibiotic? If yes, is this the current antibiotic? And am I taking antibiotics subconsciously through food or water? Unless and until we start asking these questions to ourselves, to our doctors, to chemists, to bureaucrats, to policymakers, to politicians, we're not going to solve this AMR problem. So we have to make people more and more antibiotic aware, so that these kinds of questions are asked by these common people, and subsequently solutions can be taken up. I will end up with this slide from Welcome Trust, which says that it's only when it feels direct, personal, and relevant that people take note. We took note of COVID because it affected all of us directly or indirectly. In 2020, most of us were not infected, but still we took note because everyone was under lockdown. In 2021, either we were infected or one of our relatives was suffering from COVID. Something like that happened. So we took personal note of COVID, and I could say that we could actually handle COVID much better than what we have done with AMR. So unless and until we take the AMR as a personal problem, we are not going to and make any insights into this. Thank you.
Right. Thank you so much for that wonderful insight, Dr. Nitin. So we'll be opening the forum for questions for about 5 minutes. So Dr. Nitin, we already have some questions for you. So Mr. Aman Sheikh says, does the government or the private sector take this matter seriously?
That is a very subjective question to answer. That do they take seriously? It looks on paper that yes, they do. They take the matter seriously, and they have started taking the matter seriously of late. I might say that we are already running late by taking the matter seriously so late into the already we are losing the battle, as Madam told. But yes, I think with as regards to education, they have taken a lot of things into the state hand, but we need something to come from the like the top level bureaucracy to top level government issues so that serious actions can be taken, and has been done in the past in other countries also. It has to come directly from the top level and as a holistic approach, not only picking up the fragmented, like just banning some antibiotic, over-the-counter antibiotic, sale of antibiotics. Not going to happen. We have to deal with all the aspects of AMR. Then only we're going to tackle AMR.
Okay, that's great. Thank you. So next up, so this is by Sanvedana K. Respected sir, I am doing my research on synthesis of iron nanoparticles from spider cobweb and its antimicrobial activities. My expected outcome would be able to show the zone of inhibition. I found many research related to nanoparticle synthesis and its antimicrobial activity. It may be useful in the future. Is there any views on the same?
It's totally new for me. I'm sorry, I will not be able to comment on this. I will have to read about it, and probably she can like share something which we can learn from. I'm totally new. Sorry.
All right. So Mr. Adish Kurdukar says, what does the AMR think of future scope of research in antimicrobial resistance?
So, I mean, I think he wants to know that what was AMR Declaration Trust wants to get into the
I
future.
think so, yes.
So our objective our trust objective is basically to bring all the stakeholders. Again, stakeholders does not mean only hospitals and doctors. It includes all the policymakers, researchers, new drug developers, diagnostics, the people who make diagnostic tests to come up on the. We are just going to provide a platform so that these people can come up and we can give them the required expertise, required infrastructure so that they can do their research upon it.
All right. Okay. So is AMSP strictly followed in Indian hospitals?
No, the AMSP is not strictly followed in Indian hospitals. It has started becoming a norm. I am from Delhi, so there are a lot of differences between Delhi hospitals, North Indian hospitals and South Indian hospitals. It has started becoming a norm in most of the South Indian hospitals, but it still remains an infancy in North Indian hospitals. And because of the various issues, first is awareness among the doctors. We doctors were not trained in AMSP during our training days. Another is the availability of the personnel. Like we require a clinical microbiologist, infectious disease physician, clinical pharmacist, and administrative support for AMSP. Most of these things are not available in a lot of hospitals. So these things have not been like going through. We are not matured into AMSP as of now in India. We're just at an infancy stage.
All right, that's great. So, should physicians start antibiotic dose directly or wait for some days to get proper diagnosis?
Giving the antibiotic immediately is only indicated in few of the cases, which I alluded to in one of the slides. And other, we should make maximum effort to make a diagnosis. Most of the time when we prescribe antibiotics or when we are sitting in a clinic, our job is to make a balance between how much test we can order and should we give an antibiotic. We need to have a good balance between ordering a test and giving an antibiotic. We should emphasize and exercise more on getting a diagnosis through various tests which are cost effective, and then giving an antibiotic. That's the best way around.
All right. So I find, so this is by Dr. Ashna Shaw. I find prescribing co-amoxiclav and azithral is very common, and as prescribed, as is given equal importance to paracetamol and pan-40. Even slight sore throat or pharyngitis or cough cold, although we know is viral, but amoxiclav and azithral is very liberally used. What do you think about this? And is there any way to understand when to prescribe the same?
So, there are clear clinical guidelines on when to prescribe amoxiclav or azithromycin for a patient who is having a sore throat. I don't think I need to go into this, but the question is, is this right? This is totally wrong. We need not give antibiotics like this. Who we think that it's just a viral infection. That's the problem. That is something which we need to change. That's why we need even public's help also. Because if they start asking questions to the doctors, do I really need an antibiotic? The doctors will automatically stop using an antibiotic. It's not that doctors are not aware or they still want to do the antibiotic. It's that sometimes we have come into a habit of giving prescribing an antibiotic because that is good for the patient satisfaction also. So it's a full circle. It's just becoming more and more antibiotic aware. That's what it is.
All right. I think having said that, we can conclude our Q&A session for Dr. Nitin. Next up we have, thank you so much, Dr. Nitin. Next up we have Dr. Anup R. Warrior. He is the lead consultant for infectious diseases and the prevention, Aster DM Healthcare India units. Along with, he's also the chief of medical services at Aster MedCity Kochi. And we'll be discussing how AMR affects clinical practice along with a few case-based scenarios. Over to you, Dr. Anup.
Thank you. So I'll just share my screen in a minute. So is my screen visible?
Yes, sir.
Okay. Yeah. So for next 10 to 15 minutes, with the example of 2-3 cases, I'll try to illustrate what is the impact of this AMR on treatment. So the first case is a 66-year-old female who has been a diabetic since 10 years and has been on insulin. She has a history of recurrent episodes of dysuria and pyuria. She has already done urine cultures multiple times for these, which had all shown Klebsiella pneumoniae. She has taken multiple courses of oral antibiotics, primarily cefixime and ciprofloxacin. She comes to us with fever and chills of 2 days duration. Since the fever and dysuria had started, she has already taken nitrofurantoin before she has visited the hospital. At presentation, she continues to be febrile, high grade 103 degree Fahrenheit, tachycardic, tachypneic. Her blood pressures are on the lower side, systolic of 90 by diastolic of 50. There is radial angle tenderness on the right side. With all these background clinical presentation and physical finding, we come to a conclusion that this lady has a complicated UTI, urinary tract infection, and she has probably a pyelonephritis on the right side with sepsis, right? Because in terms of fever, tachycardia, tachypnea, hypotension, all those probably points towards a possibility of sepsis. So the key points from the AMR perspective would be that to understand that this lady has multiple exposure to antibiotics of different classes. She has been exposed to nitrofurantoin, cephalosporins, quinolones. This is a very common community-based infection, right? So UTI is something which physicians see day in, day out in our outpatients and inpatients. So it's a very common community-based infection. This patient is also vulnerable, slightly on the older side with prolonged diabetes mellitus in the background. And this patient has presented to us in sepsis with hypotension, which means that inherently there is a risk of mortality. So this is not an uncomplicated outpatient-based management. This patient is in sepsis with the risk of mortality. So we are going to be quite aggressive on the management. So the questions from the AMR perspective is whether we need to cover for the MDR pathogens, that is primarily E. coli and Klebsiella in this case. What do we know about community prevalence of MDR, right? So that answer to that is what would encourage us to decide on the cover for MDR pathogens in the first place. And the question that should be cover for carbapenem resistance. Now, the impact of AMR on empiric therapy is that it affects the selection of antibiotics based on the probability of MDR in the possible pathogens, right? So in this case, because this is a urinary tract infection and this is from the community, we are focusing on common gram negatives like E. coli and Klebsiella, which causes UTI from the community. So suppose it was a pneumonia, we would have looked at possibility of penicillin resistance in pneumococcus. Suppose if it was a skin and soft tissue infection or a necrotizing fasciitis, we would have looked at methicillin resistance or MRSA. We would also consider carbapenem resistance and even colistin resistance now based on what antibiogram and what data we have from our community. So in the first section, you have seen the multicentric data from the ICMR, the antibiogram for the nation. You have seen the prevalence of cephalosporin resistance. You have seen the prevalence of carbapenem resistance. So in this background, because community acquired carbapenem resistance has been low, this patient was initiated on meropenem. The blood culture later grew ESBL Klebsiella pneumoniae, which sort of substantiates the choice of meropenem, and this meropenem was continued for 7 days. So what does this mean? So this means that meropenem is not a cheap antibiotic, it's a relatively expensive antibiotic. This patient required a prolonged IP stay because we did not have any reasonable oral step down and there was no possibility for an early discharge. So this meant a prolonged IP stay. This meant escalation of the cost of therapy for this patient who came with sepsis. Right? So this is one aspect of the impact of AMR, primarily on empiric therapy. So we are forced to use higher end broad spectrum antibiotics, parenteral, which means that the cost of therapy for the patient, including IP stay, is going to go up. Now, let us look at a second case. Okay, the same situation. So the background, everything is same. Let us assume that this is the same lady with same background of recurrent dysuria, pyuria, with same exposure to antibiotic, except that this patient is clinically stable. This patient does not have pyelonephritis, does not have sepsis, except for a low-grade fever in between and a mild bladder tenderness of dysuria. She does not have any further symptoms. So we consider this, yes, this patient still has urinary tract infection, but predominantly lower urinary tract infection and maybe cystitis. Now, when you again ask the same questions from the AMR perspective, this patient does have exposure to antibiotics. This patient is still vulnerable in terms of age and diabetes mellitus. However, from the presentation perspective, this patient is clinically stable with no features of pyelonephritis or sepsis. So how would you address the same questions in this patient? Need to cover MDR pathogens, community prevalence of MDR, carbapenem resistance, etc. Now, unfortunately, even though this is a stable patient who clinically can be managed as an outpatient, right? She's clinically very, very stable. There is no indication like the initial patient who required parenteral antibiotic because we had to manage sepsis initially at least. We could have managed this patient on oral antibiotics. Now, if you have a high MDR in your community, multi-drug resistance in your community, what are our oral options available, right? So we don't have much oral options at all. And this is a vulnerable patient. Now, suppose the susceptibility shows resistance to oral antibiotics. Still, since it is stable, how much of a chance can I take and give patient oral antibiotics? What is the impact of admission and inpatient care with IV antibiotics for somebody who just has a low-grade fever and some intermittent lower abdominal pain? What if this patient turns out to have carbapenem-resistant UTI? Right? Would you go with colistin, with in up to 1/3 could develop acute kidney injury and a small percentage going on to require dialysis support? Would you go for a newer antibiotic combination like ceftazidime avibactam, which would cost you more than 35,000 rupees a day with potential of CNS toxicity? Now, this part in terms of our difficulty to handle or manage even a stable patient as outpatients because of this risk of MDR, inability or unavailability of oral options, toxic nature of IV options for somebody who is not even septic. So that is one of the major impact again of AMR on empiric therapy. The third case is a case of again a young male. This is a different clinical scenario. So this is a 26-year-old male who has no comorbid illness. He was admitted for an elective pituitary tumor excision transnasal. On day 6, he developed fever and chills within the hospital. The chest X-ray is normal. The endotracheal aspirate was fine. The blood cultures are negative. Urine cultures are negative. Since this patient had dropping sensorium, a CSF study was done which was suggestive of meningitis. A CSF culture lateral grew carbapenem-resistant Acinetobacter baumannii. We have already seen in the initial presentation by Dr. Yamuna that 80-85% of Acinetobacter baumannii, what we isolate from the hospitals, is carbapenem-resistant. We have already seen that in the ICMR data, Acinetobacter baumannii remains to be one of the commonest drug-resistant bug which we get from our ICUs. So this patient has a post-neurosurgical meningitis, which is hospital-acquired. Now, this is a hospital-acquired infection causing meningitis or ventriculitis. This patient does not have vulnerability per se in terms of being young and no comorbid illness. However, he has developed an extended drug-resistant infection, carbapenem-resistant Acinetobacter, with very, very limited treatment options. And unfortunately, the syndrome of hospital-acquired meningitis or ventriculitis with a drug-resistant bug itself puts this patient at a very high risk of mortality. This patient is going to need prolonged IV antibiotics, prolonged ICU stay, which would put him at risk of further secondary infections. Now, this is somebody who is otherwise young and fine, who had a benign tumor, who after his elective neurosurgery would have been discharged fine and well if this infection had not occurred. Right? So what has been the impact on targeted therapy for this patient? Polymyxins remain the drug of choice for most of the Acinetobacter baumannii which we isolate. Now, unfortunately, CNS penetration is very poor with polymyxins. So now there are two drugs which have reasonably better CNS penetration, minocycline at double dose and ampicillin sulbactam at a very high dose of 27 grams per day. But for ventriculitis, we need intrathecal or intraventricular antibiotics plus intravenous antibiotics for 3 weeks or more. So this patient goes on to have an EVD insertion and external ventricular drainage insertion, goes on to get intraventricular colistin, IV minocycline, ampicillin sulbactam. So what does this mean for him? It means that he is going to have a poor outcome irrespective of the best antibiotics. He is going to be exposed to a lot of toxicity in terms of the antibiotic adverse events, and he is going to put up a lot of money for managing the cost of these antibiotics. So with the help of these 3 cases, what I would like to summarize in terms of AMR and its impact are: 1, the prevalence of antimicrobial resistance limits the choice of treatment of both common infections like UTI and serious infections like meningitis or hospital-acquired ventriculitis, right? So be it community-acquired common infections like UTI or a hospital-acquired serious infection like ventriculitis, presence of antimicrobial resistance limits your choice for treatment. That means you're going to put the patient at inferior outcomes. Many patients require inpatient management and prolonged IV access. So this has got a direct impact on cost of treatment to the patient. Sometimes, like in the case of Acinetobacter, the sensitive antibiotics are not ideal for the site of infection. So some of the antibiotics which we are left with, which would have reported as sensitive, might not be the best for a urinary tract infection or a meningitis. So that means this patient has a high risk of poor clinical outcome because you are unable to give the right antibiotic for the right site of infection. Prolonged IV access will increase the risk of secondary infections like central line-related bloodstream infections and phlebitis for these patients. The prolonged antibiotics for MDR infections will really increase the risk of adverse drug events like cytopenias, acute kidney injury, hepatotoxicity, GA problems, including Clostridium difficile. So these 5 would be the major impact from that, as somebody in clinical practice would run into problems when on a day-to-day basis we have to handle drug resistance. Thank you.
Thank you so much for that wonderful insight, Dr. Anu. So we have a couple of questions and everyone else can also put up the questions on the YouTube chat box for the Q&A session. So Mr. Mustafa says, respected sir, what's your say in antibiotic prophylaxis for streptococcal throat to prevent rheumatic fever?
So in terms of guidelines, so we have specific directives in terms of which patients would benefit and which patients do not. So based on the affection or the involvement of the wall, these decisions are made. So we have very, very definite algorithms or guidelines to approach this. And as I mentioned, that depends on the prior involvement of the heart, whether there was carditis or not.
Okay. So drugs like levonorefloxacin, carbapenem plus EDTA, cephalosporins plus EDTA, touted as new drugs. Where do these stand in the setting of MDR GNB?
So many of these, so when we look at approach to newer drugs, the starting point is that we should be able to have enough data on their pharmacokinetics and dynamics, meaning will they have sufficient serum levels at the site of infection? Like if you're treating pneumonia with epithelial lung fluid, if you're treating UTI in the urine, if you're treating meningitis in the CSF. So the drugs which we use commonly in our therapeutic practice, we have good data on their PK/PD, right? So meaning if you give this much of dose, how much is going to reach the site of infection, and based on how much it reaches the site of infection, is it enough to inhibit the growth of microorganisms at that site of infection? So many of these combinations, what we are available now, we are unable to have a say or unable to have a glimpse of this particular data, right? Hence, we are unable to comment on the dosing regimens, whether they are appropriate in terms of in vivo response and in terms of the scientific practice. That is one. The second thing which we look for newer combinations and drugs is that how do you arrive at your susceptibility reporting, right? So for susceptibility reporting, we know that you need to have an epidemiological cutoff. We need to have a particular level at which you will either an MIC level or a disk diffusion level above or below which these reporting standards are developed, right? So we also need to get information and data on this part, like how do you report these new drugs? How have they evolved at the MIC cutoffs or the disk diffusion cutoffs? So therapeutic practice or clinical usage and experience can build up on a scientific platform when you have enough information on these two. You have enough information on the PK/PD thing, so that the in vivo levels within the site of infection are deemed to be appropriate. You have enough information in terms of the MICs or distributed cutoffs so that your reporting standards are well established, and hence you can believe or act upon a microbiological report on these drugs.
Right. Okay. So I think there are no more questions as of now. So good evening, everyone. We'll be starting with the panel discussion now. Joining us for the panel discussion are our speakers for today. That is Dr. Anup Warrior, Dr. Nitin Bansal, Dr. Yamuna Devi, along with the student panelists, that is myself, Dr. Meg Nagvekar, Dr. Adnan Acharwala, and Dr. Diksha Sen. The moderator for today's panel discussion would be Dr. Anup. Over to you, Dr. Anup. I think we can begin.
Sure. Thank you. So for the panel discussion, I will start with Diksha, our colleague from the dental medicine. So
Good evening.
good evening, Diksha. So from your perspective, so somebody who is soon going to move out into practice in the field of dentistry, what would you consider the support or the initiatives or the inputs which this large group of healthcare workers who practice dentistry and dental medicine, dental surgery, can contribute towards prevention and awareness of antimicrobial resistance?
Right. Thank you so much for the question, sir. So as a dental professional myself, I personally do believe that the biggest way of tackling a topic as sensitive as antimicrobial resistance would definitely be antibiotic stewardship. So what it basically means is antibiotic stewardship is a coherent system wherein we are trying to promote only appropriate measures in the dental scenario so that no antibiotics are given as the final resort in any kind of dental treatment. So how can we go about doing this? The broadest way of explaining it is prevention is better than cure. That is the easiest way we can go about explaining the cure to a patient, how they can have fluoridated toothpaste or perhaps reduce the amount of carbohydrates in their diet so that no certain situation comes upon them wherein they need to have a drastic, say, operative surgery to be performed on them. So when I'm talking about operative surgeries, I'm talking about mainly conservative dentistry and endodontics, as well as instances of road traffic accidents, as we see in the Department of Oral and Maxillofacial Surgery. So when we're looking at endodontic treatments, usually what happens is the patient will come with a certain kind of an inflammation. Now, as a dentist, it is our responsibility to identify why that inflammation is taking place. If it is because of a heavily loaded tooth in cases of a massively filled tooth, it is our job to ensure that we are not reducing excessive amount of the tooth structure and ensuring that the restorative material is done in a way such that we can recalcify the tooth structure. In such instances, it is best to avoid any kind of antibiotics that are being prescribed to the patient so that the antimicrobial resistance can be prevented. So this is the number one ideology that we are going for as dentists, which is prevention is better than cure. Now, as far as the oral and maxillofacial surgery aspect is concerned, we come across multiple cases wherein we have a lot of road traffic accidents. Now, that cannot be you cannot have the same prevention is better than cure kind of approach to such a treatment, right? So in cases like these, it is essential to understand how the implant is going to be taken up by the patient. It is important to understand that we do have MRSA strains of bacteria as well, which is impacting our patients. So it is very important to take a thorough case history to understand the sensitivity of the case of the patient and then proceed with the respective treatment that is being provided. And that would be about it. So we have to understand as dentists that antibiotic use is not exactly a benign therapy. Prescribing medications come at a cost, and we as dentists need to ensure that we are sensitizing ourselves, we are raising the awareness, we are understanding what antibiotic stewardship is in the dental fraternity so that we can prevent any kind of resistance to come about in the years to come.
Thank you, Diksha. So if I just reiterate the main points of what you mentioned here. So irrespective of the medical specialty, prevention still is very, very important. And that's probably
Absolutely.
the first step in reducing antibiotic use. You also spoke about focusing on the diagnosis before jumping in aggressively for prescription of antibiotics. Also about reviewing the vulnerability of the patient to understand when and what kind of antibiotics to give. So that would be in a nutshell of your key messages out there. Right? Yeah. Thank you.
Right. Thank you so much, sir.
So I will move on to our next panelist, also one of our initial speakers, Dr. Yamuna. So Dr. Yamuna, since you have an extensive background in microbiology, my focus question to you is on diagnostics. So specifically, the query is that how do you think that better diagnostics will help in resistance control? So do you think at first that does diagnostic play a major role in addressing the AMR? And if so, what would be your suggestions, or what would be your idea on the gaps in the existing diagnostics that we have? Because this is also a forum for stimulating innovation and research. So that is the reason, particular. Where would you advise the newer generation to look for to bridge this gap in diagnosis?
Sure, sir. Thanks for that wonderful question, which is where the aspect of treatment stewardship always begins with diagnostic stewardship. So that is how the example of syndromic approach goes, and towards syndromic approach, you choose which is an appropriate sample to be sent for the patient, and based on which you make the targeted treatment for the patient. So that according to the diagnostic stewardship, the most important thing is appropriate specimen which has to be collected, or sample which has to be collected for patients. For example, if we have someone in the operation theater with an intra-abdominal abscess, it could be a liver abscess patient, where the surgeon performs the wonderful surgery, does the draining of the entire pus, and even after draining the entire pus, there was a very big cavitation where he planned to go for a partial removal of the liver, and he aspirates the pus, removes part of the liver, sends partially to the histopathology to see the reasoning out, and discards all the specimen. So that's where the problem comes. whether this patient is completely treated or not, or does he require some more other care. So that is where the role of importance of sending a sample to the microbiology role plays a very major role. Most of the time we see the surgeon takes out a very good no aspirated pus sample, but what do they send to the microbiology lab is just a wound swab, which is not an appropriate sample. So what we need to understand, diagnostic stewardship has got a major role. First, if you send an appropriate sample, appropriate quantity, stored in an appropriate way, and reaches the lab in the appropriate way. That is point number one. The point number two, which Sir asked, was about innovation in diagnostics. Even if we have a good lab setup, what is more expected in the clinical practice is the faster kind of a report which should be given so that you can focus the earlier treatment for the patient. So that is where the lab nowadays has moved more into automated setup of diagnostic value, where the automated blood culture reports have been done, the automated antimicrobial susceptibility have come. Even some of the molecular diagnostics have are playing a very major role, so that the diagnosis of the particular bug happens the earliest, and the report comes back to the clinical team at the earliest. So that is the innovation part. The third part is how good your laboratory is. That is all dependent on the accreditation which the lab goes for, because all labs are not good. Whatever the report given by each lab may not be the correct one, which will be useful for the clinician. So you need to know to which area, to which lab you're sending the sample. Are they reporting the microorganisms in an appropriate way and in a timely way? So I think these are the three important aspects where the diagnostic stewardship plays a very major role. So as the antimicrobial stewardship process plays a very major role, culture of culture is the most important norm whenever we are focusing more toward treatment stewardship.
Thank you, Dr. Kumar. So again, if I may just reiterate, so in many fields of science, we have heard this phrase, garbage in, garbage out, right? So similarly, if the sample and what goes to the lab is not relevant to what clinical syndrome we are looking at and what we have to handle, and as Dr. Yamuna was mentioning, in terms of transport, in terms of processing, so what you get out of it also would be garbage. So starting point of from sampling, transport, and processing in the lab has a tremendous impact on what information you get out of these diagnostics. So that has to be focused. So that was one point. The second aspect was the standards of the lab itself, because end of the day, the quality of reports do matter in terms of who handles, how it is handled, and how the reportings are done. So definitely we should focus on improving the quality of the lab, so that when we act on this result, when you are promoting clinical practice based on microbiological diagnosis, we would expect that the labs also do give us that kind of quality reports. That was the second part. The third was about the molecular diagnostics and the rapid diagnosis. So the gap in clinical medicine being access to these confirmatory diagnosis or identifying the etiology, the microbiological etiology, in as short period as a time, so that we can get to the appropriate therapy as soon as possible. So these were the three key points what Dr. Yamuna was mentioning.
So I would like to add one more point.
Sure, yeah.
Thing is, when we are sending sample, it's always requested from the clinician to mention their diagnosis, or at least the site from where the sample is taken. If it's a blood culture, it is understood. But again, if it is a pus sample and given as pus culture for sensitivity, all pus are not same. It could be a pus from a diabetic foot. It could be an intra-abdominal pus. It can be a cerebral abscess also. So the site of infection does matter, which will help out the microbiologist to make the appropriate diagnosis. So the clinical diagnosis or the clinch of clinical diagnosis has to be mentioned whenever a sample is sent to the microbiology lab for appropriate reporting.
Yeah, so again, to stress on this point, while pathologists have often been recognized as clinical pathologists, and you have regular clinico-pathological meetings and tumor board meetings, microbiologists, unfortunately, in a large section, have not come into that forefront, and the clinicians to understand and know that the clinical information has a role in terms of how this tissue is going to be processed, how interpretation of those reports has to be done, etc. So that is something which, as clinicians, all of us need to imbibe that. On in terms of microbiology, also there is a clinical microbiology that means and mandates that clinical data should be given just like pathology when we send these microbiology samples. Thank you for that input. So I'll move on to Dr. Nitin now. So Dr. Nitin, because you are also associated with ICMR, and in your session also you address this impact, or how can the public act to reduce or work on this AMR. So can you summarize on what can be done to improve the public awareness of AMR, and how can we do this? So we have a large pool of medical graduates who are hearing us now. So to this crowd of young medical graduates, or who are going to graduates or medical students, what would you recommend that what can these people and we as practicing clinicians, what can we do to improve this public awareness, and how can we do this?
So I tried to address it during my slide presentation. I will reiterate what I said that time. AMR, why public is not aware about AMR is that we don't talk about infections very specifically. To be very frank, in my, I belong to Uttar Pradesh. Anything which happens to the body, with any increase in temperature, everything is taken as infection. In fact, I work in a cancer hospital. Most of the patients get admitted. Obviously, all the patients are suffering from cancer. Still, they are the persons who are a little older or not that literate. They are told that they are suffering from some infection. That is why they are admitted in the hospital. So the infection word per se is used in a very casual way to make our patients understand what they're going through, which is not right. I think we should move along and be specific in what kind of a word we use in front of the patient. When we say infection, we should be actually mean it's an infection. So then only people will be aware that they are actually dealing with a true infection rather than just some infection. Means its infection is a wastebasket kind of a word which is used for layman persons, at least in my part of the country, where I live and where I practice. That is something which I think we should be looking into it. Education of the patient itself is very important. That they're dealing with an infection. This is an infection. This is not an infection. Second is about AMR. Now, because antibiotics are, people are not aware what is an antibiotic, what is not an antibiotic. So making people aware about what actually is an antibiotic is a big challenge. Making lay person aware about what is an antibiotic is a big challenge, because antibiotics are prescribed by, antibiotics are given to the patient over the counter also. So when there is a regulation, like the regulation which has come up of late in Kerala, such kind of a regulation is there, then the patient will realize that they will not get this drug without a prescription from the doctor. So the importance of the antibiotic will come. So they will become automatically aware about it. Third thing is that regarding antimicrobial resistance, most of the people who, unfortunately, we are talking about this, but most of the people who actually die in the hospital die of AMR. Like most of the death actually happen because of antibiotic resistance. And as you also beautifully demonstrated in your slides, that how AMR impacts day-to-day clinical practice, that one of the major issues is that it leads to inferior clinical outcomes. But unfortunately, the driving force of death is AMR, but the basic conditions for which the patient gets admitted is basically highlighted as the reason of death. So that is something which also needs to be highlighted into general public, that if we could have saved this patient from this ailment, but for the resistance in the bacteria, we could not save this patient. That is something which I think should go into the general public.
Yeah. Thank you, Nitin. So if I might add one more perspective on this. Now, one of the reasons why people are not averse to antibiotics is because the widespread belief and to a great extent truth that these are extremely safe. Right? So there are adverse events with antibiotics. In fact, of 20 to 30% of adverse drug reactions all over the world are due to antibiotics. The majority of ED admissions from drug reactions are due to antibiotics. Antibiotics have many long-term effects, like in your slides, which we are trying to illustrate in terms of quantum entanglement, etc. Like we don't know the impact on the biolife or the flora, the impact on the flora in the abdomen, how it affects the rest of things. There are a lot of connections made with chronic illnesses like asthma to Alzheimer's related to antibiotic use and change of the gut flora, right? So these also should form an important part of public education, because if doctors and public continue to believe that antibiotics are as safe as toffees, then we have a barrier, because they feel that what harm can it do? So addressing this question of what harm can it do, it should form an important part of public education. So that's just one point I would like to add in this regard of public awareness. Yeah. Thank you, Nitin. So I will go on to our remaining two panelists, Adnan and Meg, both of them who are in their medical education phase. So I'll start with Adnan. So we have initially in our presentation, and if you remember Nitin's slide, it had shown that the NMC circular, right, in October 2021, the National Medical Council saying that each medical college should have a HICC and AMS stewardship and should include this in their curriculum, etc. So Adnan, like, how do you think that within the MBBS curriculum and within the MBBS graduates, by the time they graduate, what should be done so that the good practice in terms of antibiotic and infection management can be improved?
Okay, so first of all, good evening to everyone. So, sir, when you look at the entire MBBS course, we start off from first year, and that is the period when the student is acquainted with the environment. So that's totally not the time when we get to hear things about antimicrobial resistance. Now, as I am nearing my end of second year, I this year was filled with words about antimicrobes and antimicrobials and the resistance and the stewardship and the regulations that are constantly told by us, by our teachers. So after having read some surveys by Indian medical students about AMR, a lot of the students felt that mutation particularly is the reason behind all this, and somehow we don't have a control over it because how we describe mutation to be random and spontaneous. But to some extent, that this just signifies that there is a lot of lack in awareness when it comes to how AMR is developed. So like that. So we need to understand that infection control measures is a huge aspect when it comes to AMR. And the way we prescribe medicines is important. It's not the universal truth that the more is the better. So these are the factors that we need to be taught in this training course in MBBS overall. So learning about the antimicrobial prescribing that we do in pharmacology must be connected with the infection control measures that we learn in microbiology. The significance of simple measures like hand hygiene, for example, in the control of resistance should be endorsed, and its practice should be inculcated at an earlier stage of the medical education. So one of the common misperceptions, again, which is held by prescribers while they treat their patients, again, is the more is the better in treating the colonization rather than the infection, or in using broad spectrum antimicrobials. So the students should be made aware of these important facts, as a sense of responsibility should be nurtured. That as prescribers, they are not only responsible for the benefit of an individual patient alone, but for the society at large. So for that, we need to have outcome-based education methods, which is an important tool in which the requirements are explicitly defined in detail to ensure that the medical graduates are fit to practice. So we have a lot of such techniques which are available in e-learning that we can do. So there needs to be more lectures organized, small group teachings which can be done, discussions of clinical cases and vignettes that we saw in this very webinar. And active learning assignments should be carried out, and communication skills sessions should be done about making patients aware of over-the-counter antimicrobials and how they are not they are misinterpreted a lot of times. So such peer-to-peer learning, as much as it can be maximized, it can lead to more awareness, and the budding doctors that we would be able to better handle it. And from an academic perspective, again, we need to make sure that we are a part of antimicrobial stewardship program in from an early stage. It doesn't have to be clinicians and professionals all the time. It doesn't have to be someone who holds a postgraduate degree. We need to involve ourselves into workshops, into something which can be practiced at an earlier stage and understood by us. So yeah, that is what my take on it would be.
Thank you, Arjun. So if I may reiterate the key points, what you discussed. You have again emphasized on the infection prevention aspects to be an important part of all this learning and teaching. Whenever it comes to AMR, the importance of infection prevention to be emphasized. You have talked about different teaching techniques, not just a didactic classroom teaching, but an outcome oriented or outcome focused teaching and small group learnings, etc. Into this, I would probably also add mentoring or having mentorship as an important component, because the diagnosis is one of the key aspects of stewardship. And most of the diagnosis, or at least the initial part, tends to be clinical diagnosis, like Dr. Nitin's case of sore throat. Every physician should have the clinical competence to diagnose viral pharyngitis without a PCR of the throat, right? So that requires mentoring, and not to prescribe azithromycin, considering this could be streptococcal throat. Okay? So you should have that much clinical judgment and exposure and experience to make confidence of a viral fever, viral pharyngitis, dengue fever, without complicated use of diagnostics, etc. So that would also form the mentoring as a part of learning from this aspect.
Yes, sir.
And you have also reiterated the best practices for prescription, the antibiotic best practice for prescriptions, which should be inculcated into the medical students as a part of their training, right? Thank you.
Yes, sir. Thank you, sir.
So coming to make as a follow through of what discussions which we had, my first query would be that, again, this is a take up from what Dr. Nitin showed as the NMC circular. So somebody who is being active with the medical graduate students, probably who has got insights into the happenings in various medical colleges. It has been about 6 months or plus now, from October 2021 to now. So do you think that there has been any headway in this NMC circular? Are you aware of any activities or any initiatives being undertaken in these medical colleges based on this circular? That is one. And second, more specifically, suppose you had a say in what to teach. Okay. And Adnan has given a very brief in terms of good and prescription practices. But again, coming to the nitty-gritty of this, suppose you had a say on what should be in the MBBS curriculum from the AMR and AMSP, the stewardship perspective. What would be your suggestions on that?
All right. Thank you, sir, for that question. So I'd like to first address the second question, that is, what would be my take on the medical curriculum in terms of AMR and AMSP. And then I'll go on and iterate about how the NMC circular has impacted the medical education. So first of all, when we, of course, talk about AMR, so currently in the medical education, we have been discussing from a very theoretical point of view when it comes to definitions, types, mechanisms, some frequently encountered AMR such as beta lactamases, etc. But I feel, some topics that we do need to address are the extent of the problem and the clinical repercussions of AMR. So I feel like, like Adnan said about the small group discussions, the small group teachings, the peer-to-peer teaching methods. So I think even these can be included as SLOs, which are an important part of the CBME curriculum. So of course, CBME, as we know, is the competency-based medical education. And of course, I feel SLO, which is the specific learning objectives. So something about extent of problem, the clinical repercussions of AMR, even we can include topics about AMR for PG exams, since these are the kids which will form the future chunk of our clinicians. So that's the first thing. Then, as Dr. Nitin rightly iterated about the clinicians, administrators, and general public perspective, I feel knowledge should not stop at a theoretical level. We should also go into, for the medical education primarily, we should also go into how exactly, practically we could tackle AMR, which Dr. Nitin rightly reiterated. And as I said, theoretical is just a way of learning, but practicality is how we can actually implement the same. So, well, talking about AMSP, that is Antimicrobial Stewardship Program, for all our viewers who don't know what that is, it is the right antibiotic for the right patient at the right time, in the right dose, and in the right route. So currently, as Anand said, in our second year MBBS microbiology subject, so we've been learning about the implementation of antimicrobial stewardship program, some things about the monitoring, the compliance, and the rational use. But I feel we could also focus on the 5 Ds of the antimicrobial stewardship program. That is the drug, the de-escalation, discontinuation, and the dose, as well as the diagnosis. So I feel, we always talk about a lot of case-based discussions when it comes to, the competency-based medical education. So now coming on to, the NMC curricular. So of course, we always, like I said, the CBME curriculum is more of a case-based scenarios, which we have been trying to incorporate into our medical education. Apart from that, what I feel is we could also have integrations, such as horizontal integrations of microbiology with pharmacology, wherein the pharmacology department can deal with the drug, the mechanism of action, etc. And the microbiology department can deal with the types of antimicrobial resistance and how we can tackle the same. We shouldn't just stop at the horizontal integration, but even vertical integration with our clinical subjects, such as medicine, surgery, obstetrics and gynecology, pediatrics. I feel when we discuss a case-based scenario and when we get to the management of the same, we should also discuss the antimicrobial stewardship program and its policies when it comes to prescribing certain drugs for any illnesses or any pathologies that are there in the body. So I feel horizontal and vertical integration are what we've been trying to do since the NMC circular has come out. And it's still, of course, at a very beginner phase, but of course, with a little more, input, with a little more effort, I think these integrations can go a great way into adapting AMR and, tackling AMR at a clinician level. Apart from that, so there is a concept of electives, which are incorporated into the CBME curriculum. So electives are basically a clinical insight, which, so it's basically, so it's about a 2-month course at the end of your first MBBS. So the first month is for preclinical subjects, and the second month is for your clinical subjects. So in the clinical subject electives, I feel, all the medical institutes all across India can try to incorporate, AMR and AMSP programs, especially because it is not a very theoretical learning objective, but it is more of, actually being out there. Because as we mean by electives, it is basically an observership sort of, learning aptitude when the students are actually out there in the field and they learn the workings of these departments. And, there in this scenario, I feel, the microbiology department can really be of help with AMR and AMSP electives being offered to the students. I think as of, I know, as from what I know, none of the colleges, in our vicinity have been offering AMR and AMSP electives. But I think with, a little more incentive, a little more effort from the, central board, I think we can definitely try to incorporate AMR and AMSP into the electives as well as the medical curriculums.
Thank you, Meg. So if I summarize the major point in is what I take back is that what you would really like is to have a change in both structure and the delivery of the curriculum in such a way that the theoretical aspects of what you're learning is seamlessly integrated into practical implementation or clinical practice, right? So there is a seamless integration. So you are able to see the spectrum from end to end. So starting from the bug to the drug to the patient and to the outcome. That's what I take back from what you have discussed. I think we are well within time. We are just 9:45, that is 1.5 hours. And so I'll give it back to Meg and we'll end this panel discussion and you can take it up from here. Thank you.
Right. Thank you so much, sir. So I'd just like to discuss a question that is, how can AMR trust with RC Medicrew percolate into teaching medical schools? This is more of a very administrative point of view, but RC Medicrew, we at RC Medicrew have been dealing with, most of the medical colleges in India, and we have about more than 3,000 members all over India. So what we can try to do is we can try to arrange seminars, we can try to arrange observership programs, we can try to arrange, a panel discussions at multiple medical colleges. So of course, a very good time to do these would be the fests that happen in medical colleges. So as I think everyone here knows, we have the research part of the fest. So in the research part of the fest, I think, topics such as AMR could go a very long way. And of course, with the work that the AMR Trust is doing, I think if, we can try to incorporate this into, medical schools and try to bring about this change by having panel discussions, seminars, and other stuff. So I think with some effort from our end as well as the trust's end, I think we can definitely bring about the same. So having said that, I'll just open the forum for any questions, after which we'll be concluding the meeting. Right. So Mr. Ganesh Kumar has a question. What will be the drug of choice if colistin and polymyxin resistance is found in AMR? Combination therapy recommended.
So do you want me to take it up?
Sure, sir.
You want me to answer this?
Right.
So this is a very specific question. Colistin and polymyxin B is resistant. Now we have moved along. We have got newer antibiotics also, which are being used to treat infections which are resistant to polymyxin B and colistin also. But like ceftazidime, avibactam plus aztreonam, and there are other more antibiotics which are in the pipeline, which will be available in India soon. But we don't want us to be reaching at that level where we are dealing with infections where we actually don't have an option. So that is something which we need to be aware and tackle that accordingly.
Right. Thank you, sir. So the next question, how often do we vary from guidelines designed largely for the Western population in India? Can anybody explain this variance in practice in India along with an example?
I take this. So, for example, Western guidelines, just for example, Western guidelines recommend using vancomycin to cover MRSA in all the patients who are admitted with pneumonia. Whereas in India, that situation is not that common. What remains more common is the prevalence of gram-negatives even in patients with pneumonia. Obviously, the most common bug here in India is also Streptococcus pneumoniae. But after that, we have a lot of other bugs like Burkholderia pseudomallei, even Klebsiella pneumoniae, which causes severe pneumonia, which is far more ahead than MRSA, which is there in the Western world. So that is a problem. When we blindly follow Western guidelines, we land up with problems. And I would like to also highlight here that ICMR has also come up with an antibiotic guideline app, which basically is like a mobile app version of the National Antibiotic Guidelines, which were published in 2019 by ACMR, which actually looks into these kinds of aspects where we have given antibiotic recommendations based on the Indian scenarios and Indian data.
Right. Thank you, sir. So the next question is, do we have comprehensive national Indian guidelines for antibiotic use, and how can we access it to incorporate in practice?
Yeah, these are already available. National antibiotic guidelines are already available. You can Google it also. And as I said, the ICMR app is also available. It's available both for the iPhone and the Android version also. Both are available. So literature availability is not an issue. National guidelines. And actually, it is recommended that the hospital forms its own antibiotic guidelines also. And you will find that most of the bigger hospitals in India have their own hospital antibiotic policies as well.
All right. So I think there are no more questions on the YouTube chat box. So any questions that the panelists would like to ask? Right. Okay. So, well, so as Dr. Joshua Lederberg rightly said, the future of humanity and microbes will likely evolve as episodes of our wits versus their genes. Well, if we use antibiotics at a time when it's not needed, we may not have them when they're most needed. Through Dr. Yamuna Devi, Dr. Anup, and Dr. Nitin, we learn how to sensitize ourselves about antimicrobial resistance. It is our responsibility as members of the healthcare fraternity to understand the intricacies of antimicrobial resistance and its impact it has on our patients. Only then we'll be able to take on every case with a different outlook and understand the impacts our treatment has on the general masses. Well, with that being said, I'd like to conclude today's session. Over to you, Adnan.
Yes, thank you, Meg. We at Rotaract Club of Medicrew extend our sincerest gratitude to the AMR Declaration Trust for this exceptional event, and which was very successful. To our esteemed guests and speakers, Dr. Nitin Bansal, Dr. Yamuna Devi, and Dr. Anup Warrior, we also thank Dr. Abdul Ghafoor and Dr. Vasant Nagwekar for their constant guidance and support. We hope that this collaboration has brought our members beneficial knowledge about antimicrobial resistance and the stewardship program. We wholeheartedly foresee future events and even on-ground events with your organization. Thank you so much.
Thank you so much, everyone. I'll now stop the live streaming.